Hello, everybody. We are going to be covering today in this lecture Chapter 16, Therapy and Treatment of the textbook OpenStax, um, which is obviously the last chapter in the textbook. So this is the end of the semester. I certainly hope everybody has enjoyed this class and has maybe learned one or two things that you can apply in your everyday life. That is certainly the goal of this class. Psychology is such a wonderful, large, universal field that I really feel confident that all of you have taken something you can take with you either in your personal life or your professional life or academically. And certainly, if you are interested in this course and it piqued an interest in you in psychology as a field, there are many more courses that are being offered in different types of psychology, such as abnormal and growth and development and other fields. So I definitely would encourage you to look into some of those if you are interested in psychology as a field. So without further ado, let's get through this chapter. It's a fairly short lecture, fairly short chapter. Many forms of therapy have been developed to treat a wide array of problems. These Marines who served in Iraq and Afghanistan, together with community mental health volunteers, are part of the Ocean Therapy program at Camp Pendleton, a program in which learning to surf is combined with group discussions. The program helps vets recover, especially vets who suffer from post traumatic stress disorder. There's actually a multitude of different um, programs that are set up similar to that. I know of one here that uses yoga that was set up between a yoga studio and MacDill Air Force Base. By here, of course, I mean Tampa, Florida, Tampa Bay area, which is where I live. Um, MacDill Air Force Base is a rather large Air Force base located in Tampa, and they teamed up with a local yoga studio to offer this program. And it actually serves on a couple different fronts. First off, was just rehabilitative as far as from injuries that the vets may have sustained. And then the other one was as far as mental health and relaxation therapy. And yoga can be very effective in all those areas. Um, so really the way this lecture is going to play out is sort of a chronology where we talk about the earlier treatments and then move on to more recent treatments, and then finally bring this to the present day and we will talk about some of the treatments that are going on currently. So to kind of give a little bit of a general overview, mental health treatment, approximately 19% of US adults and 13% of adolescents experience mental illness in a given year. The percentage of adults who receive mental health treatment in 2004 to 2008 is shown below. Adults seeking treatment increased slightly from 2004 to 2008. Some of that may be the result of better diagnosis. Some of it may be the result of changing socioeconomic situations. 2008 was sort of when the economy started getting a little bit worse, generally speaking, when those stressors start to present themselves. And there's no better stressor than money or finances. Mental health can sometimes start to deteriorate, and we can start having some issues with things like depression and anxiety. So about one third to one half of the U.S. adolescents with mental health disorders receive treatment, with behavior-related disorders more likely to be treated um, rather than other types of disorders. So treatment in the past. Throughout most of history, mental illness was believed to be caused by supernatural forces, such as witchcraft or demonic possession. People with mental illnesses at this time were often subjected to cruelty and poor treatment. We talked about this briefly when we actually started this course, and we talked about some of the history of psychology. And I think it really is worth noting that this really wasn't too long ago in which people viewed mental health disorders and mental illnesses as being something like demon possessions or witchcraft and things like that. So the fact that we've come from where we are and the reason why we talk about this past, even though it is kind of a bad past, it's something that paints psychology in a bad light. But bear in mind, this was also before the foundation of psychology. Psychology wasn't founded as a field until the late 1800s. Um, but we can't really appreciate where we are until we know where we've been. So that's why we kind of go over some of these past treatments, and I use treatments very loosely when referring to some of these things, like exorcism and trephining. Exorcism involving incantations and prayers said over an individual's body by a priest or religious figure. Sometimes, obviously now when we say exorcism, it kind of elicits um, visual images of things like the movie Basic Exorcism, with the priest praying over the girl, and her the devil coming out of her, basically. Some extreme forms of exorcism, though, really basically amounted to child abuse, or just abuse in general when it wasn't a child. This include basically tying the person down onto a bed, starving them, depriving them of food, water, you name it, basic hygiene. And indeed, in the past, people have died from exorcisms, and not necessarily from the demon leaving the body, but more from the treatment they actually received during the exorcism from those who were actually performing it. Trepanning is something we talked about, I know, before in chapter one, but that is something that's actually been going on across multiple cultures for thousands of years. And that's with the boring of a hole into the skull in order to release bad spirits from the person. Frequently, and I mean, you bear in mind, even today, it wouldn't be it'd be very risky to bore a hole into somebody's skull. But when you think about this being done for thousands of years without the benefit of things like anesthesia or antibiotics, it was it had extremely high fatality rates. One of the other things that's interesting is that the people who did survive this type of treatment, obviously it wasn't a cure for it, but it went on for thousands of years, likely because the people that were exposed to this quote unquote treatment were probably very, very, very unlikely to admit to still having problems with the mental health disorder that they were struggling with. Whether or not they still had those symptoms or not, the last thing they would want to do if they survived having a hole drilled into their brain or into their skull was to risk having a second one drilled into their skull in order to allow more demons to come out. So, from the outside observer, it probably seemed like it did work, and that's probably why it went on for as long as it did, because usually the people who were exposed to it weren't going to let on that they were still suffering, so they basically pretended or tried to hide it as best they could. Um, and finally, execution or imprisonment. Many mentally ill people were burnt at the stake after being accused of witchcraft. To this day, I would say, as far as imprisonment, we'll go into that a little bit later, but it's interesting to see some of the correlations between those two things, mental health and imprisonment rates. So as we move forward, we're going into the 1700s. By the 18th century, 1700s, people exhibiting unusual behavior began to be institutionalized. This is the development of the first asylums. So the first institutions created for specific purpose of housing people with psychological disorders that happened during this period. The focus was ostracizing them from society, so it wasn't necessarily designed to treat these people. It was more designed to just get them away from everyday people, put all these crazy people in one little area so that they're not bothering with society anymore. That was the initial goal of these asylums, not for treatment. Um, a gentleman known as Philippe Pinel, this is in the late 1700s, was a French physician. He kind of solved this situation with these asylums just basically being places to banish people to that were suffering from mental health disorders. And he really did not like the way that was being done. He kind of championed for more humane treatment. Um, he kind of viewed one of the ways of treating them, even though this is even before the period where psychology was developed as a science into itself. He really believed that one of the best ways of treating these people was through actually allowing them to interact with other people, allowing them to talk, not ostracizing them, isolating them, keeping them by themselves, but actually encouraging basically what would be considered social behavior, group behavior, as being a treatment for them. Another interesting person early on, while talking about the treatments, actual legitimate or the beginning of legitimate treatments, is Dorothea Dix. She was a social reformer, and this is in the 1800s now. She became an advocate for the indigent, insane. Investigated the state of care for the mentally ill and poor, and discovered an underfunded and unregulated system that perpetuated abuse of the mentally ill. She was very instrumental in creating the first American mental asylum by relentlessly lobbying state legislatures and Congress to set up and fund such institutions. Again, though, kind of keep in mind, even the American asylums, they were still pretty subhuman conditions. They did offer a little treatment, and part of the reason why they offered a little treatment was because, again, psychology wasn't established until the late 19th century and really wasn't, productive science in the treatment of disorders until well into the 20th. So there really wasn't anything as far as treatment to be offered. Um, the basic gist was still to use asylums as basically being a place just to isolate people to. Um, and essentially, once you were in one of these asylums, you pretty much stayed there until you died. There was not really any idea as far as going to one and coming back out because you were cured. Because again, very little treatment was offered. There really wasn't any type of formal treatments offered at this time, and they really didn't know how to cure or treat these disorders. Some of the treatments, quote unquote treatments that were developed around this time was submersion in cold baths for long periods of time and electroshock treatment. There's a form of this now, which is called electroconvulsive therapy. It involves a brief application of electric stimuli to produce a generalized seizure. Um, there's a difference. There's a form, again, electroconvulsive therapy is kind of a variation of that is used now to a far lesser extent. It doesn't force somebody to have seizures, it just applies a very minute amount of electricity that is barely even noticeable by the person in order to try to help with some of the electric transmissions of the neurological system. That is totally different than what was going on with electroshock therapy and even electroconvulsive therapy. Um, the goal there was to apply very high doses of electricity, and indeed, it essentially would end up debilitating the patient. So conditions such as these were very common until well into the 20th century. The change really happened in the United States about the mid part of the 20th century. By 1954, antipsychotic medications were beginning to be developed and prescribed. They proved to be successful in treating symptoms of psychosis. So, again, we're not really talking about treating a disorder to the point that we're curing it. These are just dealing with symptoms of those disorders. Psychosis in and of itself was a common diagnosis. It was evidenced by symptoms such as hallucinations and delusions, indicating a loss of contact with reality. Psychosis in and of itself is not a disorder anymore. Um, a lot of the people that were diagnosed with psychosis were either going through extreme manic episodes for certain disorders, such as bipolar disorder, or, and this is largely the case, especially when you're talking about people who are committed to asylums, they were people who suffered from schizophrenia, um, and those were probably the most prevalent people that were placed in an asylum, and of course that were given these diagnoses of psychosis. By 1975, there was an act passed by Congress called the Mental Retardation Facilities and Community Mental Health Centers Construction Act. It provided federal support and funding for community health centers and started the process of deinstitutionalization. this is where we're at currently in this country, is this process of deinstitutionalization. So essentially what we mean by that is we're trying to, and we have pretty much closed most mental health treatment facilities. Most states still retain one or two, but they are very few and far between. They are not meant to be long-term treatment area centers. They're meant to be essentially short-term centers meant to bring somebody up to a quote-unquote normal or healthy level. And they are typically parts of the correction system. So essentially, what we would be doing, or what these hospitals are being used for, is to bring somebody who's mentally incompetent to stand trial up to a normal level so that they can stand trial, unless they're judged to be completely incompetent to stand trial, or for the treatment of those who have already been judged to be mentally incompetent. Um, a lot of times they can be sentenced to those types of hospitals, but these are very rare circumstances. And generally speaking, the preferred way that we handle mental health in this country, in the United States, is through community centers. So bringing us up into today, mental illness among the homeless population is still very common today. Of homeless individuals in the United States, shelters, about one quarter have a severe mental health illness. Correctional institutions also report a high number of individuals living with mental illness. A couple things to just go into about this. Um, Homelessness, again, not saying that somebody who is homeless necessarily has a mental health disorder. However, those with mental health disorders, especially the more debilitating ones like schizophrenia, have a very high likelihood of becoming homeless. Um, the other thing on here that I really want to kind of make a point of is the correctional aspect and what generally some people consider to be the criminalization of mental health. And this is honestly basically a course unto itself, could be taught just on the correlation between corrections, law enforcement, and mental health treatment. But essentially, what's happened in this country was with the closing of mental health asylums and the vast majority of mental health hospitals, what we found is that oftentimes those people who are suffering that are in our community, because again, most treatment centers are community focused. So these aren't people that spend the night in, months on end in a hospital. They're people that live in apartments, live in halfway houses, live with their family members, come in for treatment, and then leave and go back out into the community. The problem where this comes in is that these people still maybe act bizarrely. Maybe other people, the community at large, aren't adept at understanding maybe what those people are going through. And they find themselves to both A, be victimized by the community at large, and also B, to victimize the community at large also. Although these are far fewer. People with mental health disorders are many times more likely to be the victims of crime than to perpetrate a crime. But due to what could be considered bizarre behaviors, different issues such as a higher prevalence of use of illegal drugs, people with mental health disorders find themselves also being incarcerated far more. Also, some of the answers that we have now, since we don't have mental health treatment hospitals like we did back in the day, is that if somebody is going through a period where they're not taking their medication, where they're not complying with treatments, or maybe they're dealing with particular stressors and they're going through really pronounced manic episodes, or with schizophrenics where they're really becoming delusional, there's not really a large amount of options available. If the person is a danger to themselves or others, as an imminent threat of committing suicide or of killing somebody, then they can be involuntarily committed, which we're going to touch on here in a second. But if they don't meet that criteria, law enforcement as a whole still has to deal with that problem. And a lot of the ways that they end up having to deal with it is through arresting the person. So that's what we're talking about when we mention the criminalization of mental health. Asylums have since been replaced with psychiatric hospitals and local community hospitals focused on short-term care, and this is mental health treatment today. The emphasis is on short-term stays. Average stay is less than 2 weeks. And indeed, really the focus, I would say, isn't even on residential treatment as far as where the person stays there, but one where they have their own home, they have their own halfway house, apartment, whatever the case may be. Due to high costs of psychiatric hospitalization, insurance coverage often limits the length of time individuals can be hospitalized, and that is pretty much only relevant to those who even have the insurance in the first place. Individuals are usually only hospitalized if they are an imminent threat to themselves or others. So, this is the two main types basically of treatment. We have voluntary treatment and involuntary treatment. Voluntary kind of speaks for itself. It's where the person recognizes they have a problem and seek treatment for it. They consent to that treatment. However, every state in the United States, every jurisdiction in the United States has provisions for forcing treatment on somebody who isn't viewed as not being in the right mind to make those decisions for themselves. And that is true of not just psychiatric disorders, but even things like people who have brain injuries from an accident. They may be saying that they want to refuse treatment, but if they're not in the right mind to refuse that treatment, treatment can be forced on them. With psychiatric disorders, though, it's a little bit special because um, essentially what we're looking at with this is whether or not the person is an imminent threat to themselves or to other people. Um, and generally, with the involuntary treatment, this is involving doctors, it's involving law enforcement. Oftentimes, it can involve the court systems. Um, it can be both immediate as far as, somebody who's going through a really difficult bout of major depressive disorder and starts to feel suicidal, where that person can be taken to a treatment facility. It'd be a residential facility. Usually they're have to be seen by a doctor within about 3 days. And then they're released once they no longer fit the criteria of being actively suicidal. So that would be more of an acute onset of involuntary treatment. Something that would be more long term would be somebody who, say, as a result of their mental health disorder, did get involved in criminal activity. Now they're under conditions for like probation or some form of community control or some form of sentencing. And as part of that sentencing, or as part of those conditions, the judge is ordering that they seek uh, counseling or psychiatric support groups, things like that, say once a week, twice a week for however long. Some of the sources of psychological treatment: community health, mental health centers, private community practitioners, school counselors, school psychologists, or school social workers, and group therapy. Treatment providers include psychologists, psychiatrists, clinical social workers, marriage and family therapists. Um, a multitude of different practitioners now exist, and they all have different titles. Generally speaking, though, of course, psychologists do not prescribe medication or order medical testing. In some states, that is changing, but generally, this is the big division between psychologist and a psychiatrist. A psychiatrist is a medically trained doctor, and they are able to prescribe medications and order medical testing. However, because their focus is more on that biological component, they generally do not provide counseling sessions, treatments, things like that. And again, I'm talking generally. It doesn't mean every single one doesn't, but that's usually the way it is. Clinical social workers, marriage and family therapists, those are generally people with master's degrees. So a psychologist and psychiatrist, they both have doctorates. A psychiatrist is a medical doctor, and a psychologist usually has a PhD. With clinical social workers, marriage therapists, things like that, they have master's degrees, and they definitely are focused more on the counseling aspects, group therapy aspects, things like that. You also have, which is not listed on here, things like physician's assistants, and advanced registered nurse practitioners that work within the framework of psychology or underneath a psychiatrist. And they're also more focused, and they have master's degrees. They're more focused on the prescribing of medication, regulating of hormones, things like that, the more medical aspects of psychology. So going into some of the specific therapies that are actually, or treatments that are actually used today, one of the first ones we're going to talk about is psychotherapy. Psychotherapy is very strongly based on psychoanalysis. It's psychological treatment that employs various methods to help someone overcome personal problems or to attain personal growth. Biologically based treatments or medications can also be used to treat mental disorders. Biomedical therapy involves medication and or medical procedures to treat psychological disorders. Most often, it's used in combination with psychotherapy, and that really is kind of the basic concept. If you could think back to the biomedical, or I'm sorry, biopsychosocial triangle, that's kind of the gold standard of what we look at for treatment now, is to treat the biological through medication, the psychological through one-on-one care, coping skills, therapy, and then the sociological component would be more group therapies and integrating the person into their community, into their relationships with family, friends, loved ones, things like that. So the specifically psychoanalysis fits more of the psychological component, and it's dealing more with therapy. It's the first form of psychotherapy. It was developed by Sigmund Freud back in the early 20th century. As I said, it's very strongly focused on that whole psychoanalytical theory. It's aimed to help uncover repressed feelings and memories. Some of the techniques that they use is something known as free association. The patient relaxes and then says whatever comes to mind at the moment. Freud theorized that the ego would try to block unacceptable urges or painful conflicts during free association, causing the patient to demonstrate resistance. And then how they delved into those free association topics kind of led the course of the therapy session. Another component of this was something, dream analysis, something that I'm sure many people have kind of wondered about and looked into, where the dreams could be interpreted as being results of subconscious urges, feelings, conflicts. Another big concept that was used or technique is transference. And in transference, patient transfers all the positive or negative emotions associated with their other relationships to the psychoanalyst. Um, Today, psychoanalysis is less popular, but Freud's perspective has been expanded upon by incorporating modern theories and methodologies. Freud was very instrumental. However, a lot of the things he did come up with, they were instrumental in that he was the first person to bring them up. But since that time, they've been refined, they've been changed quite a bit. So the classic example of Sigmund Freud and what he came up with no longer really has much weight. But it did lead to the development of a lot of other things that are very much so still present today. Um, Specifically with psychoanalysis, the version of that that's present today is known as psychodynamic psychotherapy. And what that is basically just talk therapy. So a therapist and the patient. Um, it's a talk therapy based on belief that the unconscious and childhood conflicts impact behavior. Um, that just goes into a little bit more of the slide about psychoanalysis. Uh, the kind of classic example of a therapist and of psychology is this, person laying in the couch, laying down and just freely talking. A lot of times, as you can see here, the chair was where the therapist would sit. So the person laying down on the couch wouldn't even see the therapist, and oftentimes wouldn't even communicate with them or anything else. They would just talk while the therapist just sort of wrote down what they were talking about, took notes, maybe interjected rarely, but otherwise the process was generally to have the person talk and be open with that free association. Psychoanalytical therapy also incorporates something known as play therapy, and this is actually used by other types of therapists today, especially with children. Play therapy is a psychoanalytical therapy where an interaction with toys is used instead of talk. It's used in child therapy. It's also used, believe it or not, with adults. It's used to help clients prevent, resolve psychosocial difficulties and achieve optimal growth. The technique is toys such as dolls, stuffed animals, sandbox figurines are used to help children play out their hopes, fantasies, and traumas. Sand play or sand tray therapy is where children can set up a three-dimensional world using various figures and objects that correspond to their inner state. Picture of that seen here. Therapists generally sit back, they observe, they watch how these children interact or play out different things, or sometimes even adults, and again, take notes of that and then use it through the therapy session, kind of bring up and talk to the person about maybe why they felt a certain way or why they acted a certain way with this therapy. And there are two types. There's a non-directive play therapy and a directive. So with non-directive, the difference there is that the children are encouraged to work through problems by playing freely while the therapist observes. And directive play therapy is where the therapist actually kind of provides the structure and guidance to guide the patient through that play therapy. So one is much more passive role for the therapist. That's non-directive, and directive play therapy is one where it's much more active, where the therapist is actually engaging with the patient. Behavior therapy, that's another form of therapy that's very common today. Principles of learning are applied to change undesirable behaviors. It's based on the belief that dysfunctional behaviors can be changed by teaching clients more constructive behaviors. Um, and again, obviously, you're talking about behavior therapy. We're talking about really the behavioralist view of psychology or field of psychology. So we're talking about learning. Classical conditioning principles are applied to recondition clients and change their behaviors. Counter conditioning is where a client learns a new response to a stimulus that has previously elicited an undesirable behavior. It includes aversive conditioning and exposure therapy. Both of these very, very common now. Aversion conditioning is using an unpleasant stimulus to stop an undesirable behavior. It's used to eliminate addictive behaviors. A client is repeatedly exposed to something unpleasant, such as a mild electric shock or a bad taste while they engage in a specific behavior. And then by doing that, it leads to the client learning to associate the unpleasant stimulus and unwanted behavior. It should be noted that classical conditioning plays a really big role in addiction and not necessarily aversive therapy with electrical shocks or anything like that. But another form of aversion therapy can just be letting the person know and letting them see and being aware of the negative consequences of those behaviors. That could also count as aversive therapy. Exposure therapy is very interesting, and it's used a lot um, for anxiety disorders, for phobias, and believe it or not, it's actually also used a lot of times for things like post-traumatic stress disorder. So with exposure therapy, it seeks to change the response to a conditioned stimulus. So it's used to treat fears or anxiety. A client is repeatedly exposed to the object or situation that causes their problem, with the idea that they will eventually get used to it. Now, this isn't an immediate process. So, say if somebody has a fear of heights, over the course of perhaps several months or weeks or even years, you'd go to therapy, you'd speak to the therapist. It would start with the therapist, whether that be a psychologist or a counselor or whatever, giving the person ideas as far as how to deal with the negative parts of that fear. So, talking about fear of heights, they'd sit down, they talk about different coping skills, breathing techniques, different ways that the person can deal with stress in general and those fears specifically. Then they'd start talking to the patient And instead of actually straight on confronting the fear, they may just have the patient talk about being in a high place and how that would make them feel and being aware of those feelings. Then they may do baby steps and build up to it. It's called shaping, right? So now we go from knowing how to cope with the stress. We're talking about these stressful situations. Now the therapist may actually have the person start going up to higher positions, but maybe at first it would just be a step stool. And then once they're fine with that and they're acceptable to that and they're no longer getting a negative response, then they'd build up to higher and taller objects until essentially the fear no longer exists. um, this is another example here of the basically classical conditioning and how it's used in exposure therapy. um, Essentially, what you are doing with exposure therapy is this concept here. It's called systematic desensitization. So what you're doing is by doing those baby steps, by exposing somebody to something that is fearful or stressful to them, and you're allowing it to do it in a very therapeutic way that is trying to minimize some of those stressors and the negative aspects of the fear. Um, you're slowly getting to the point where the person no longer fears that object or that situation anymore. And a neat way that technology is coming into play now is something known as virtual reality exposure therapy. So, with that, we're using simulation to help conquer fears. And that's especially useful for things that it's too impractical to really go into, or perhaps there's ethical issues or safety issues at play. So, say somebody has some kind of unreasonable fear of, say, snakes. It may not be necessarily feasible, practical, safe for a therapist to bring snakes into a therapy session, um, nor maybe to bring the person to a pet store or something like that, where they may be afraid of then being ostracized by people walking around, other customers. So perhaps then a virtual reality thing is more acceptable because it's more controlled, and doesn't risk kind of ostracizing or making the person feel embarrassed by going to like a pet store and freaking out when they see a snake. Operant conditioning now, with what we've talked about so far, we've focused on the classical conditioning part of behavior therapy. Now it's the operant conditioning part. So it's based on the principle that behaviors become extinguished when not reinforced. Applied behavior analysis uses operant conditioning techniques to, it's designed to reinforce positive behaviors and punish unwanted behaviors. It's effective in helping children with autism. Child-specific reinforcers such as stickers, praise, candy are used to reward and motivate autistic children when they demonstrate desired behaviors. Punishment, such as timeout, might be used to discourage undesirable behaviors. What this leads to, or an example of this in action, is something known as a token economy. And a token economy is something that's actually used a lot in a variety of different settings. It's used in controlled settings such as psychiatric hospitals, but it can also be used in certain other things. For example, in the past, I've actually been a client of Weight Watchers. Weight Watchers uses token economies. It's where inanimate objects, tokens, coins, some kind of metal is given as a reward for achieving certain goals or doing certain achievements. So whether it's in a psychiatric hospital, it's the person getting up on their own, making their bed, and showering, preparing themselves hygiene wise. And that may be a big achievement for that person. Maybe somebody who's depressed really doesn't want to feel that way or do those things. So it's a big achievement for them to be able to do that on their own. So they would get a token for that, and they'd collect a certain number of tokens, and they'd get certain rewards for that. Weight Watchers does something, or at least they used to do something very similar, where you'd get little medals for each goal that you achieved. And then, you'd discuss it during the meetings. People would give you praise and whatnot for achieving those. Another really good example of the token economy is Alcoholics Anonymous, and they do the same thing. They use tokens or coins to celebrate certain milestones, like, 1 day sober, 5 days sober, week sober, month sober, so on and so forth. So, cognitive therapy, and to reiterate something I've talked about during several different chapters, the general main field of psychology, if you will, the thought process in psychology now does marry the behaviorist perspective with the cognitive perspective. So generally what we talk about is behavior cognitive therapy or cognitive behavioral therapy. Cognitive therapy in and of itself, though, was developed by Aaron Beck back in the 1960s. It's based on the idea that how you think determines how you feel and act. Cognitive therapy focuses on how thoughts lead to feelings of distress. Emotional reactions are the result of your thoughts about the situation rather than the situation itself. So, kind of makes sense when we know what cognitive field of psychology is. Cognitive therapy focuses on those thought processes and how you can change perspectives. um, some key terms to remember with that, you have overgeneralization, and these are basically pitfalls of our thinking that lead to dysfunctions or distortions and issues with our mental health. So the first one is overgeneralization. That's taking a small situation and making it huge. So say you go out, you wake up in the morning, you go out to start your car to go to work, the car doesn't start, and all of a sudden you just start thinking, well, look at that. This is the kind of luck I have, and then you start applying all these other different situations of misfortune that have happened to you recently, and you just say, why does this happen to me? Just all these bad things always happen to me. That tends to be an overgeneralization. It's something that's very easy to do, especially when you do happen to have a few misfortunes happen in a row, but it's a pitfall really of your cognitive processes. The second one is polarized thinking, or also known as black and white thinking. It's seeing things in absolutes. I am either perfect or I'm a failure. If I don't do a fill in the blank task, then I'm just miserable. I'm horrible. Look at me. Of course I deserve to, have not be in a relationship or not have a job or not have whatever. I can't even do whatever it is that you didn't do, right? So most people can relate to all these because you think or have thoughts like this. It's what makes you a human being. If it gets to the point that it is difficult for you to deal with, then that's where you do need to seek help. But all of us think in these terms at some point. All of us overgeneralize. All of us have polarized thinking. And then finally, all of us at some point do the jumping to conclusions, which is assuming that people are thinking negatively about you or reacting negatively to you without evidence. Um, Again, all of us, these are very common. If you're experiencing any of them, you are a human being. You are allowed to experience these. It's when they become problematic that you do need to start seeing help for it. Clients are helped to change dysfunctional thinking patterns. This is getting back to just cognitive therapy as a whole. Clients are helped to change the dysfunctional thinking patterns by challenging irrational beliefs, focus on their illogical basis, and correcting them with more logical and rational thoughts or beliefs. So that's kind of an example there, a little flow chart of how that would work. Two big types, and I'd say the CBT, the cognitive behavior therapy, is probably the most common that's used now as far as this marriage. And again, cognitive behavioral therapy, cognitive behavioral field of studies or school of thought is kind of the predominant one in psychology today, especially with therapists or people that have clinical practices. Um, there really are two types. There's the cognitive behavioral therapy, and then there's rational emotive therapy, which it kind of started with the RET, but most people now it's the CBT, it's the cognitive behavioral therapy. So it works to change cognitive distortions and self-defeating behaviors. It aims to change both how people think and how they act. It helps clients examine how their thoughts affect their behaviors. So a combination of cognitive therapy and behavioral therapy. And the way that kind of works is they do go hand in hand. When you think about a lot of who you are as a person is the result of your experiences, which is totally behavior driven. That's learning. Um, but what you're really learning is kind of your perspective on things, and that's a cognitive process. So it's a yin and yang. You can't really change your perspective and how you view things if you don't understand how you got that way in the first place, which was through behaviorism, was through learning. And likewise, then you can't really change out of that without recognizing it and understanding it and learning new ways to learn, which is behaviorist. So the CBT therapy uses something known as the ABC model to reveal cognitive distortions. Um, and by distortions, this is what we talked about in the last slide, things like overgeneralization, black and white thinking. So what the ABC model is the A stands for action, which is the activating event. B is the belief about the event, and then C stands for consequences, which is consequences of the belief. Humanistic therapy focuses on helping people achieve their potential. The goal is to increase self-awareness and acceptance through focus on conscious thoughts. This was originally developed back with Carl Rogers, and it was something known as client-centered therapy. This isn't necessarily a field unto itself or a school of thought unto itself. Rather, it was a concept that came up that was basically adopted in all parts of psychology. And the goal here is to focus more on the person, the patient, and on helping that patient, not on being judgmental, not on being overly detached and scientific, which was the case prior to Carl Rogers coming along. Was that people were patients were basically kept at an arm distance. The therapist or the psychiatrist, psychologist was viewed as basically observing this person and diagnosing them, not as trying to make a personal connection with them in order to help them. Which is really where we're at today with the humanistic approach. And some of the techniques they incorporate are listed there. They're fairly self-explanatory. One of the big ones is this unconditional positive regard. Therapist does not judge clients and simply accepts them for who they are. Do not get this incorrect in thinking that, and most people go to this extreme, is, oh, okay, so if you're a therapist and somebody comes in and they say they just killed somebody, you're supposed to say that's great. That's not the case. That's an extreme example. But you are supposed to acknowledge that person and view what they're saying and what they're doing as being the acceptable manifestation, how they're manifesting themselves. Um, the good, the bad, the ugly. So finally, we're going to get into some of the biomedical therapies. In my opinion, today people rely too much on um, psychiatric medication. It plays a very, very important role, but the role it plays is to basically allow for a stable and immediate stabilization and to help the person for most psychiatric disorders, so that then therapy can come in and actually provide somebody with more longer term, healthier treatments. So really, most psychotropics should be for shorter term treatment. But what happens is that people think that a pill is just a cure. I can just take a pill and, that's it. My bipolar disorder is fixed. My depressive disorder is fixed. Um, and that's not necessarily the case. There are some disorders, such as schizophrenia, that you're going to be on that medication for the rest of your life because it is such a strongly linked biological disorder. Um, and it can be treated through other ways, but the primary way of treating it is through medication. Um, some of the categories are listed there as far as psychotropic medication. Those are medications used to treat psychological disorders. So that's pretty much what we're talking about with psychology as psychotropics. An antipsychotic is used to treat positive psychotic symptoms such as hallucinations, delusions, paranoia by blocking dopamine. Again, with that, we're pretty much talking about schizophrenia specifically. Atypical antipsychotics treat the negative symptoms of schizophrenia, such as withdrawal and apathy, by targeting both dopamine and serotonin. Antipsychotics and atypical antipsychotics both treat schizophrenia and other types of severe thought disorders. Antidepressants, on the other hand, they alter the levels of serotonin and norepinephrine. And really, what we're talking about for most of these are working in that reuptake of those neurotransmitters. So either they block the reuptake or they work by increasing the reuptake or increasing the receptors that accept those neurotransmitters. So antidepressants, obviously, we use those a lot for depression and for anxiety. And then we have anti-anxiety agents, which are used for anxiety, OCD, PTSD, panic disorder, social phobias. Mood stabilizers, those are usually used specifically for bipolar disorder, sometimes depression. Stimulants are used pretty much exclusively for those with attention deficit hyperactivity disorder. Um, Electroconvulsive therapy, we talked about that before. It is still used today. It's not used at the extent that it was in the past, and it's certainly not at the scope it was. The purpose here isn't to trigger seizures or make somebody essentially debilitated with the electricity. In fact, the type that's used today is barely even noticeable by the person. And it has been shown to help those with depression. Um, Another thing that is coming that has been used more recently is transcranial magnetic stimulation, which uses magnetic fields to stimulate nerve cells to improve depressive symptoms. Both of these, electroconvulsive therapy and the transcranial magnetic stimulation, have the same basic concept at hand, which is to increase the activity in the brain, increase those the neurons firing essentially, and the electrical impulses going through your neurological system, and by doing that, help elevate levels of neurotransmitters, increase brain activity, which decreases depression. Some of the modalities we're talking about, and in this, we're not talking about specific therapies, but rather the way those therapies are done. Um, a lot of these are pretty standard, pretty self-explanatory. I'm not going to go too far into them. Read over them though. Obviously, we have one-on-one. There's certain things that lend themselves more towards group therapies. Addiction is one that is especially useful for group therapy, and a lot of that is based on having that community support, which is really important. And part of that biopsychosocial triangle is the social and integrating yourself into a community, whether that community is your family, your friends, or a sub community of former alcoholics, former addicts of opioids, former victims of sexual abuse, whatever the case may be. Those can be really instrumental in those group therapy sessions. Um, Another thing that is very common, right? So we go from individual therapy, one-on-one, group therapy, larger groups, are more individualistic type modalities like family therapy, where you're just incorporating the family unit, say, mom and mom, dad and dad, mom and dad, whatever the parental unit is, with the children to try to work on the communications between those groups. Couple therapy is something that a lot of people, it sort of has a bad rap. Actually has a really good success rate. In fact, a lot of people essentially do a preemptive couples therapy, during their newlywed period to try to maintain that level of happiness rather than wait until there's an issue and then go to family therapy, or I'm sorry, couple therapy rather. And that's kind of the reason why couple therapy actually has such a bad rap is a lot of people say, oh, you go to couple therapy and all it does is help you basically break up with the person. Well, the problem is most people wait until there's issues and they wait until those issues have reached a breaking point before they even go to therapy in the first place. So it's kind of going upstream to have to work against that to try to mend what's already been broken. So oftentimes it does come down to just helping ease that transition into a couple breaking up. However, that's not the fault of the therapist per se. It's not anybody's fault. It's just kind of the way it is. And for that reason, like I said, some couples actually choose to go when things are going well, to try to increase that happiness and maintain it through different communication techniques and things like that. Substance related and addictive disorders, that is a very large component in and of itself. Um, please look over that chapter. I'm not going to go into it too much because the book actually explains it very well. Do know that addiction is extremely prevalent with individuals that have psychological disorders. It is also a huge burden on our society, both financially, um, psychologically, socially, criminally, in almost every factor you can think of. Addiction is a huge burden on our society. Um, social cultural models. Again, I'm not going to go into that too much either. Please review it. Essentially, I already reviewed a lot of it as far as talking about the biopsychosocial model. Um, do know that obviously the gold standard and what psychiatrists really look for is to incorporate that social component in any kind of therapy, whether that social component is group activities, the larger community, or if it's more specific to loved ones, family members, friends, things like that. Um, in closing, this is the end of the term, this is the end of the class. It has been an absolute pleasure being your instructor. I certainly hope I have been a little infectious with my love of psychology and passing it on to all of you. Please, by all means, if you still have any questions, any concerns, reach out to me. And that offer doesn't just go to the end of this term. If there's anything you're ever struggling with in your future endeavors, and you maybe need a little bit of guidance or help as far as psychology or as far as not counseling, but just more from a advice aspect coming from a professor, please feel free to reach out to me. If you're looking to get into psychology as a field or as a career, by all means, if you want some guidance on that, reach out to me. I'll be more than willing to help you. Um, I really hope that you enjoyed this class, and I wish you the best of luck in your future endeavors. Take care, and best of luck to you.